If two patients, 130 and 175, present in the emergency room with identical severe visceral cramping, standard clinical heuristics often steer them toward completely different diagnostic pathways. The diagnostic algorithms and symptom patterns that reliably identify gastrointestinal disorders in younger adults routinely break down when applied to patients over 65. For instance, diagnosing a new-onset functional disorder like irritable bowel syndrome in an elderly patient is a statistical anomaly. Irritable bowel syndrome is a functional condition characterized by abdominal pain and altered bowel habits occurring without any structural or biochemical abnormalities. In this older cohort, those exact same vague symptoms almost universally indicate an underlying organic disease, a developing malignancy, or an iatrogenic cascade caused by a medical intervention. The mechanism driving this divergence is physiological senescence. Normal aging along rarely causes frank organ failure, but it drastically depletes the gastrointestinal tract's functional reserve. This depleted reserve mutates how diseases progress and alters the physical presentation of symptoms, muting the classic warning signs clinicians are trained to spot. This chart shows the probability of underlying pathology organized by age. Notice that at the 65-year mark, the likelihood of organic disease spikes sharply, while the probability of a true functional disorder plummets. Attributing vague abdominal complaints to normal aging without a rigorous investigation is a statistical trap. A healthy gastrointestinal tract relies on a robust baseline of motility, nutrient absorption, and mucosal immunity. As we age, the gut undergoes immunosenescence. Lymphoid tissue blunts defenses, increasing pro-inflammatory cytokines like IL-1B. Simultaneously, the myenteric plexus degenerates, slowing gastric and colonic transit. The mucous bicarbonate layer thins, and blood flow shrinks, stripping the stomach's defenses. The physiological margin for error vanishes entirely. Because this functional reserve is severely depleted, even a minor superimposed stressor, such as a routine medication change or a mild bacterial exposure, can easily trigger acute, localized organ failure. The aging gut constantly operates in a state of chronic, low-grade inflammation, making it highly susceptible to transforming ordinary systemic stress into severe gastrointestinal disease. In the upper GI tract, structural alterations frequently mask severe tissue destruction, delaying crucial diagnoses. Consider presbyphagia, normal age-related changes in the swallowing mechanism, including upward displacement of the lower esophageal sphincter and non-synchronized tertiary muscle contractions. However, sudden dysphagia, difficulty swallowing, is an absolute alarm symptom indicating an emerging malignancy. Gastroesophageal reflux disease behaves similarly. Older adults frequently lack the classic symptom of heartburn due to an age-related dulling of visceral pain perception. Instead, this silent GERD presents atypically, manifesting as an unexplained chronic cough, wheezing, or persistent hoarseness. The consequence of this muted presentation is severe. The disease destroys tissue long before a patient reports discomfort. As a result, older populations face significantly higher rates of erosive esophagitis and Barrett's esophagus, a precancerous cellular change. Similarly, true new cases of functional dyspepsia, a chronic disorder of sensation and movement, drop off sharply after age 60. Prescribing empirical treatments for indigestion in this age group without investigation carries massive risk. Endoscopy is mandatory to rule out Helicobacter pylori infections, peptic ulcers, or gastric cancer. In the upper GI of an older patient, the absence of classic pain does absolutely nothing to rule out the presence of severe, life-threatening disease. In the small bowel, peristaltic motility generally remains intact with age. Instead, nutrient absorption and vascular supply become the prime targets for hidden disease. Celiac disease is a prime example. In the elderly, this autoimmune enteropathy triggered by gluten exposure rarely presents with the textbook symptom of chronic diarrhea. Elderly celiac disease masks itself, presenting only as iron deficiency anemia, bone fractures, or neuropathy. Similarly, chronic mesenteric ischemia is insidious, caused by the slow stenosis of visceral arteries. Blood flow struggles to meet metabolic demands, causing abdominal angina, vague bloating, and food avoidance. This persistent food avoidance leads to severe, unexplained weight loss, which clinicians frequently misdiagnose as a hidden malignancy, delaying proper vascular intervention. Small bowel diseases in the elderly often bypass gastrointestinal complaints entirely, presenting instead as systemic malnutrition or vascular starvation. In the lower GI tract, we encounter perhaps the most dangerous clinical pitfall in geriatric gastroenterology, diagnosing an older adult with irritable bowel syndrome. The onset of true, new irritable bowel syndrome after age 65 is an incredibly rare phenomenon. If an older patient presents with IBS-like symptoms, cramping, bloating, and altered bowel habits, the differential diagnosis must immediately prioritize organic pathologies. The first hidden culprit is microscopic colitis. This inflammatory condition of the colon is invisible to the naked eye during a standard colonoscopy, but causes chronic diarrhea, often triggered by routine medications like NSAIDs or statins. The second culprit is symptomatic uncomplicated diverticular disease, or SUDD. This illness causes abdominal symptoms attributed to diverticula without overt macroscopic inflammation, perfectly mimicking IBS-like bloating, but requiring entirely different management strategies. The ultimate threat is colorectal cancer. The probability of colon cancer spikes heavily with age, hiding effortlessly by vague functional symptoms. Assuming an IBS diagnosis delays colonoscopy, allowing a tumor to silently engulf the colon wall while clinicians treat a benign disorder. Because standard colon cancer screening guidelines generally recommend stopping routine checks at age 75, strict symptom-based investigations are often the only remaining safety net for these patients. Reaching a diagnosis of a functional lower GI disease in an older adult is a diagnosis of exclusion that should almost never actually be reached. This brings us to the concept of the iatrogenic cascade. Routine medical interventions frequently exploit the aging gut's depleted functional reserve to trigger a chain reaction of systemic failures. Take the NSAID pathway as an example. Standard anti-inflammatory painkillers easily breach the already thinned mucosal barrier and reduced blood flow of an older stomach, causing silent, lethal bleeding ulcers. Proton pump inhibitors, or PPIs, follow a similar cascade. Suppressing stomach acid in a gut that already suffers from slow motility creates the exact environment bacteria need to bloom. This specific pharmaceutical combination connects directly to the onset of small intestinal bacterial overgrowth, or SIBO, an abnormal accumulation of bacteria in the small intestine, as well as recurrent, treatment-resistant Clostridioides difficile infections. Treating new-onset inflammatory bowel disease with corticosteroids triggers yet another cascade. In the elderly, steroids frequently cause severe metabolic shifts, opportunistic infections, and rapid bone density loss. To prevent these cascades, clinicians must stop relying strictly on chronological, age-based guidelines when evaluating treatment risk and diagnostic pathways. The necessary clinical tool is the Comprehensive Geriatric Assessment, or CGA. This is a multidimensional diagnostic process used to determine the true medical, psychological, and functional capabilities of a frail older person, prioritizing their biological resilience over their mere age. When guided by a CGA, rigorous diagnostic workups, including invasive procedures like endoscopy, are both ethically and medically justified to uncover hidden organic pathologies. In the aging gut, the atypical presentation is the typical presentation. Diagnostic clarity requires unwavering clinical suspicion and a refusal to dismiss a patient's symptoms as just another symptom of growing older.